and we are talking about monkeypox, which has actually been talk of various places to figure out what's going on in the world. Okay, so we have Dr. Alfonso Morales. He's a professor, researcher, biomedicine research group, faculty and senior researcher at Columbia and Peru University. He's a president for Columbia Association of Infectious Disease. He's a member of Council of International Society of Infectious Disease. I was looking at his profile. He has more than 30 pages, so it's a very small introduction for him. He has a lot of research on it, and he's been working on monkeypox. He's been talking about the aspects and epidemiological aspects of monkeypox. So I will invite him for the presentation. Over to you, sir.
Thank you very much. First of all, thank you for the invitation for this presentation. I have no direct conflict of interest to declare for this presentation. And I would like to start remembering that we are still dealing with the pandemic, the COVID-19 pandemic. This is it's an important start because first, we are still dealing with this situation in multiple countries with new waves, with the recombinant variants, with Omicron recombinant variants, and still with some vaccine hesitancy, as many other related issues in a moment where we are not still clear where are we going right now with the COVID pandemic, and if we end this pandemic in the near future, even this year or maybe the next coming. And with this in mind, it's important also to remember that we have a very tiny line between different factors, multiple risk factors, and the next pandemics or next significant epidemic of different emerging infectious diseases, not only SARS-CoV-2, but we have to remember that right now in Middle East, for example, there have been confirmation again of cases of Middle East respiratory syndrome, the adenovirus 41 hepatitis, in co-circulation and even in co-infections with SARS-CoV-2. And as I mentioned, in relation with climate change, migration, deforestation, contamination, animal and human contact, travel, and even the war in Europe, among other factors. In this setting, emerging and re-emerging vector-borne and especially zoonotic diseases are quite important. And these diseases especially affect the most vulnerable population, as our Nobel Prize in Literature says, Gabriel Garcia Marquez, in their novels, death does not come with old age, but with oblivion. And certainly, neglected diseases are important in the context of the tropical settings, and these also include many zoonotic diseases. So at a certain point, we also may say, as we had in this editorial in Frontiers in Tropical Diseases, that we are living on the edge of this constant threat of zoonotic and vector-borne emerging tropical diseases that, for example, are related to climate change and the consequence of this, the poverty, the trade, deforestation, urbanization as well, and travel. And certainly in many countries, for example, here in Latin America, deforestation is leading to different infectious diseases, especially those for example, related to rodents. Rodent-borne viruses are quite important, for example, here where we have, for example, hantaviruses, where we have a different clinical presentations from these hantavirus, now called orthohantavirus, producing not only pulmonary syndromic, but also even a renal failure, as we have published in different publications. But when we talk about these rodent-borne viruses, we are also talking not only of hantaviruses, but for example, we are talking of a group, for example, of arenaviruses, now called mammarenaviruses, that, for example, here in Latin America are related to a group of viral hemorrhagic fevers, such as those occurring in Bolivia or in Argentina, Brazil, and even here in Colombia, in relation to these viruses that are transmitted by different rodent species. And this is, as I mentioned, related to climate change, for example, associated to deforestation. And this has a clear impact of a lot of zoonotic diseases right now. Understood. Even last year here in Latin America, in Venezuela, that has been a country significantly affected by the social and political crisis, there is a re-emergence of the Venezuelan hemorrhagic fever, another rodent-borne virus. Maybe some of you are questioning about why we're talking about rodent-borne virus, because certainly monkeypox was originated in monkeys, but this is also a rodent-borne virus originally in Africa, and different rodent species are related to the zoonotic transmission in different ecological settings in the primary transmission in this continent by the way of contact with rodent, different rodent, different, for example, arboreal as well as territorial or other type of rodent species, as we will discuss later. So the question these days, as you have seen in the media, is if there's time to worry or one to ignore. And certainly you already know that last week, WHO convened the Emergency Committee on the under International Health Regulation in order to assess if this may be considered a public health emergency of international concern, and still is not. But this is something that will be certainly reassessed in the near future. We are talking then of a DM virus that is related to smallpox. It's in the same genus as an orthopox virus, and this is part of the family of Poxviridae, which is important to mention that these include a lot of different genuses that affects a lot of different animals. And in fact, monkeypox is not the only zoonotic orthopox virus. It's important to remember the case of cowpox, but maybe other viruses in this family may also have a similar pattern and needs to be quite certainly studied in the near future. But certainly, monkeypox has been originated in monkeys, and this was described in the 50s in Denmark. This is not a disease originally described in Africa, as many people right now think, but instead of that, in Europe. And it's important to remember that what was described originally in Africa were the first human case. And this is the typical pictures from the literature describing the clinical manifestations of the vesiculopustular rash described initially in African countries that we will discuss later. But certainly, when we talked initially on monkeypox during this 2022 outbreak, the first is that people is comparing with smallpox. It is important to certainly make some discussion of the key features of both viruses. That monkeypox, fortunately, is less infections. Right now, we will talk about what is happening with vaccines. This is a virus with no circulation in Africa since the 50s, and in humans especially since 1970, with the description of the first case in the Democratic Republic of Congo. But in comparison with the smallpox, vaccines were used until 4 decades ago because the disease was eradicated. In fact, the only human viral disease that has been eradicated in the 80s, with the last case in 77 in Somalia, and these led to the stopping the vaccination for smallpox. But certainly both have similar transmission routes, but we will discuss what is happening right now regarding monkeypox and new issues related to this emerging disease. Certainly, the case fatality rate, fortunately, is less important than what happened in the past with smallpox, especially with the Mariola Mayer virus, which had approximately 30% of case fatality rate. The West African clade, and we will discuss later the new classification, had 1% of lethality, and the Central African clade around 10%. Well, as we mentioned in this journal in Trial Medicine Infectious Diseases some weeks ago already, is that in fact we are in a never-ending global emergence of viral zoonosis after COVID-19, and this is right now spreading relatively rapid across different continents and multiple continents. Fortunately, this is not a new virus, and its genome is well known right now, and especially after the COVID-19 pandemic, the molecular detection and sequencing, genome sequencing in different countries has been enhanced. This is not only the case for North America and Europe, but especially also in Asia, in Latin America, and even in Africa, although it's still limited in different countries. But this is right now very important, especially to identify the clade, which is also related, as I mentioned, with the clinical presentation, which is milder and less lethal in the case of the West African clade compared to the Central African clade. And right now, what is related is mostly to West African clade, but in fact, we will see later that there is a proposal of a new classification regarding this phylogenetics of monkeypox virus. But also, monkeypox can be seen by this kind of electron micrograph, as you are looking here, and some of the cases in this outbreak has been even also detected by electron microscopy. But certainly, as I mentioned, I would like to highlight that this is described initially in Denmark. This is the first paper related to this in 1958. These are the first pictures related to the description of this monkeypox, precisely in cynomolgus monkey in macaca, as you will see, affecting arms, also the face, producing this rash or POTS-like disease that was originally described. But certainly in these studies, early, they demonstrate cytopathic change, producing human amnion cell cultures, and this is important to understand also that this is pathogenic for human beings, but even for many other animal species, as this was also, for example, inoculated in rabbits. But certainly, they even in this paper described that probably this was occurring before, probably in Brazil, but this is not well known, but it's interesting related to this paper of 1922. That means a century ago, describing some outbreak among monkeypox during a smallpox outbreak in Brazil. And this was even later described in this primates book, but it's not clear. But certainly, animal reservoirs or hosts, at least, are important. For example, Gambian poach rats, as I mentioned, this is important different rodents that are related. As you will see here, different genesis that have been at least detect seropositivity, but especially the case of the prairie dog of cynomolgus that even affect different organ and system. That this is important for these species of cynomolgus that affect different organs. But also, as I mentioned, arboreal rodents, such as is the case of a squirrel, has been also detected from a long time ago. And certainly, the question here right now, among different multiple questions, is this monkeypox and other reemerging viral zoonosis with many animal hosts yet to be defined, because it has not been studied in deep detail, for example, in Africa, and even for other members of the genus Orthopox virus that also affect other different animals. And certainly, for example, in this bibliometric analysis, we will see that before the first outbreak outside African countries in 2003, that is well known, there was a significant low level of research before this. And after that is that you will see an increase in different databases regarding the number of articles and studies that have been published in relation to monkeypox. Even this is up to 2021. And right now in 2022, there is already more than 100 papers that just in few weeks have been published related to monkeypox virus. And this has been also confirmed in this short communication in Lancet regarding that. But now focusing on the clinical aspects, certainly our main concern in different countries receiving the first cases of monkeypox virus, for example, here in Colombia, that we confirmed the first cases just a week ago, but also in other countries in Latin America as well, in other continents, is how similar is the clinical presentation of monkeypox, for example, not just with the smallpox that was eradicated, but for example, varicella, that is varicella or chickenpox, that is still very important in many developing or low and middle income countries. But what key different clinical finding is the lymphadenopathy that, as you see here, this is a characteristic of monkeypox, but it's not present in smallpox, neither in varicella. And this is one of the key aspects during the clinical presentation. This is important, and it's not the only lymphatic organ or tissue that is affected during monkeypox, but this is a part of the lymphadenopathy, cervical lymphadenopathy described, for example, in case from Africa. But certainly what is expected, but not necessarily the clinical presentation right now outside Africa, is is the rash. The rash may be a lot of lesions, this one, and we will discuss later about this, but certainly maybe very few compared to these cases in Africa. Still, regarding, for example, the immune response in this infection, there are still a lot of things that are necessary to understand, but certainly some studies in last decade have raised the importance, for example, of the increase of certain cytokines, especially in the case of IL-2R, IL-8, IL-10, and maybe are related to complicated disease, which is not common, but it's important to identify that, as we will discuss later. But from an epidemiological point of view, certainly the world began to be concerned after the outbreak in the United States in 2003. Before that, this was not really highlighted outside Africa. But in Africa, this has been well known in different countries, as was the previous classification, because this is now proposed to change. The West African clade, especially affecting countries such as Nigeria, Cote d'Ivoire, Liberia, Sierra Leone, and also Cameroon, that is affected, in fact, has been affected by both clades. The other clade, which is more pathogenic, more lethal, the case of the Central African clade or Congo Basin, affecting, for example, the DRC, the Central African Republic, Congo, Gabon, Sudan, but as I mentioned, also Cameroon. But as I say, this has been a proposal that it has been adopted already by some articles and different groups in the world to try to convene in just this approach in three clades. The first clade, which corresponds to the prior Congo Basin or Central African clade, the clade 2, the clade 3, that this clade 2 and clade 3 is constitute the prior West African clade, and in clade 3, this contains most of the genomes from the imported cases during 2017, 18, and the current 22 human outbreaks outside Africa. In terms of epidemiology, we have to look, first of all, that this has been affecting especially African countries over the cases. The case of the DRC, with increase in the number of cases over time. For example, in this systematic review from Beer and Rao in 2019, increasing from 2001 to 2013. And this is important to consider that probably this has been underestimated and even neglected. And this is an interesting paper from this year discussing that. This underestimation of this is important, discussing different aspects, the increased rodent-human interaction that probably led to increased transmission of monkeypox in Africa, but not it's not the case outside Africa. But certainly, for example, other aspects such as the importance of the new estimation of the basic and effective reproduction rate, which is right now required, and I will discuss later. So in some countries, this is important to better understand increasing and engaging the epidemiological surveillance, but certainly in some studies, for example, in DRC, have been identified that the major increase in monkeypox is probably also related to the cessation of or stopping of the smallpox vaccination. And this has been studied, for example, in DRC in different ecological settings where, for example, in the forest, there is a highest incidence, especially in the case even of children, for the incidence of monkeypox per 1,000 population. But over the last years, there have been also imported cases to United States, to United Kingdom, Israel, Singapore, as well, probably many other countries, even in the African continent. But right now, there is a rapid dissemination in different continents, especially the case of Europe, as we may see. And even when we developed this editorial, we were asking if we will have quickly cases, for example, here in Latin America. But certainly the first outbreak that was considered important outside Africa was in 2003. This is a well-known history, which this was related to zoonotic transmission and not sustained human-to-human transmission. But again, these remember us the importance of the illegal wildlife trade, which is a gateway to zoonotic infectious diseases in the case of monkeypox. But we have again to remember the COVID-19s and pangolins and many other infectious diseases in Africa, in India, Australia, as well here in Latin America. But the case of 2003 in the United States was very interesting in terms of the relation with the prairie dogs used as pets and infected because being in contact with African rodents, such as the Gambian poached rat, and the limited zoonotic transmission that occurred, especially in children in contact with these pets, that was confirmed, obviously, by molecular and genome sequencing with phylogenetic studies confirming this. Right now, multiple agencies have been alerting or warning what is happening with this situation of imported, but even not related to imported cases, which has many implications, as we also will be discussing later. And it's important to see that this is a very changing scenario, not only from the epidemiological point of view, but especially from the knowledge regarding transmission and many other aspects I would like to discuss. But it's important right now that we are understanding better the phylogenetics and the genomic epidemiology of monkeypox due to a better sequencing capacity we have in the world. It's important to mention that nevertheless, this is going relatively rapid. You may see here that from May 6 to May 20, just 2 weeks, 30 countries report monkeypox in the world, especially in the case of Europe. And these figures progress rapidly to those cases, less than 100, 200 cases, to right now for today, or in your case tomorrow, with over 6,000 cases that have been confirmed in different continents and in more than 50 countries all over the world. In Europe, North America, Latin America, in Asia, Australia, as well, even in non-endemic African countries, such as, for example, the case of South Africa. Here, rapidly in Latin America, this is progressing rapidly, and we have already cases, especially in Brazil, in Argentina, but this has been disseminated relatively rapid. Mexico, Venezuela, here I am in Colombia, in Peru, in Chile, and Argentina, and we have prepared this publication that will be released in a few days in Lancet Regional Health Americas, discussing not only the implication of this situation, but the preparedness that we are assessing to face this multi-country human monkeypox outbreak, not only globally, but especially here in the region. Maybe it's important to see that some countries are showing this curve, this epidemic curve. For example, this is from United Kingdom that has reported mainly their cases in England and especially in London. And with this epidemiological data, it's important to look and to reassess, as I mentioned before, which is the basic reproductive number. This, for example, with data collected from DRC, probably is less than 1, which is not allowing an epidemic or sustained transmission. But other estimation using, for example, 85% of vaccinia efficacy, meaning effective coverage against monkeypox, not only smallpox, with the equations proposed in this paper, allow to calculate a monkeypox R sub-zero of 2.13, which is smaller for smallpox, but is still larger than 1. We have to remember, for example, the case of measles, which is the highest, around 18, but estimations for COVID-19, 2 to 3. If we took the elderly population, which is less than 10%, and we extrapolate to this curve that consider this number or proportion of immunity in population to orthopox virus, based on these propositions, probably we are around these figures, but this needs to be assessed. What is important is also the spreading associated right now to different events, to super spreading conditions, such as has been, for example, the gay pride parties, for example, in Portugal, in Spain as well, in Belgium, that has been associated to different clusters of the disease. And you know that with coronaviruses, super spreading events contribute to transmission. And this was also the case, for example, in cruise ships, and for example, here in Latin America, religious events such as the Holy Week. And certainly right now, what is important from this point of view is to assess, for example, how sexual content networks contribute to this sustainability of the transmission of monkeypox, because although we can say still this is a sexually transmitted infection, sexual contact, intimate contact is contributing to the transmission of monkeypox, as has been reported in different publications. And probably this is a preprint in medRxiv, important to say the importance of mass gatherings that may contribute to a significant basic reproductive number and needs to be considered among these epidemiological factors. In other epidemiological variables, it's important to mention that most cases have been described in males, especially men who have sex with men in an age that are obviously sexually active, with an important description of genital ulcers. And this is quite different from the classical description in African countries. It's important to mention that during this 2022 outbreak, a number of patients has been hospitalized, especially in Germany, in Italy, in Spain, among other countries. And it's important to assess if in some cases it may evolve to complicated forms or not. Fortunately, yet not confirmed cases have been related to an fatal outcome, but this is important still to assess. Recently, over the last couple of weeks, has been important to mention from the epidemiological point of view that we are in the route to say that monkeypox is also sexually transmitted, not exclusively, but it's a route of transmission that probably is also important. And right now, we may say from different papers that the virus is detected in seminal fluid, as you may see here. This is the first paper in neurosurveillance confirming this from the group of Antinori in Italy, also detecting this in plasma, in genital or rectal lesions, in nasopharyngeal swab, skin lesions in feces. This is important, that has been detected. Probably, they demonstrate viral shedding, whose efficiency in terms of transmission cannot be ruled out, but we have to consider this possibility. In this preprint for Germany, in 2 cases also, monkeypox has been detected also in semen. And in this case, also it's important to consider that that sample should be taken in order to assess this detection, not only from cutaneous lesions, but also, for example, from semen. Here in this report, an additional report from Italy, recently published a few days ago in Trial Medicine Infectious Diseases from Davide Mileto and Dr. Spinello Antinori, they also detect monkeypox on seminal fluid. So this is important, and this is the question right now. If the monkeypox is another sexually transmitted infection, not exclusively, but as a route, additional route, as I mentioned. And right now, to address this question, this is a special issue we have open in Pathogens Journal. And if you are working on this, you are invited to submit different types of articles to this special issue. So this is evolving. Multiple countries are increasing, especially in Europe, to report this. And which is interesting is the change from the classical clinical evolution to maybe a typical clinical evolution, as we may discuss. But this clinical evolution is summarized in this image that we have published a few days ago in Infeczioni Medicina, the Italian journal of the Society of Infectious Diseases, where you have 3 periods: an incubation period up to 3 weeks of duration, and after that, a period of invasion with fever, chills, headache, myalgia, lumbago, malaise, intense asthenia, and lymphadenopathy, as I mentioned, with a fever that is prolonged, especially during this invasion and during the incubation and invasion. This is apparently not infectious. We may say apparently because this may change, and I will show you some recent preprint that is concerning right now regarding this. During this period is the primary viremia with viral replication in primary target, peripheral lymph nodes and blood. And after 3 to 5 days, there's a meet open, please, if you may close, thank you. And where we have the skin eruption, and this skin eruption is the period where people is infectious. You have the rash development from few to severe thousand lesions. You may see here the classification based on the World Health Organization, and the evolution from macule, papule, vesicle, pustule, and finally across or escape the falls. Okay, this is a companion with pruritus and pain. As I mentioned, this rash, vesicular-papular rash, occurs 1 to 3 days after fever. This is a period where there is initially viral replication without viremia in secondary targets, and some days after with a secondary viremia with a replication, the possible replication in tertiary targets such as skin, heart, kidney, and other organs. I would like to say also that this paper confirmed the incubation period, as I mentioned, of 3 weeks. I will not discuss further on the result, but it's important. What is important also to mention that we need more research on the basic signs related specifically to monkeypox cellular infection, because we are using information from pox virus, but not specifically from monkeypox virus regarding, for example, the ligands and receptors that are used to infect cells, if these are the same or not, for example, used by vaccinia or smallpox, but has been implicating chondroitin sulfate and heparan sulfate, for example, as ligand for these events of, for example, viral fusion or endosomal uptake via micropinocytosis-like mechanism. But there are some papers related to that. But again, for vaccinia virus confirming this addition to the cell using, for example, chondroitin sulfate, heparan sulfate, and other molecules. But it's important, as I mentioned, that other lymphatic organs, for example, spleen, are places for the reproduction of the virus. The spleen and liver, as you may see here, this is a child in Gabon, in Lancet many decades ago, showing this. But I would like to, for closing the presentation, to talk that what we are looking right now outside Africa is an atypical presentation. For example, this is a case in neurosurveillance reported a few weeks ago, with an initial genital rash, and the fever appeared days after that, appearing later, diffuse rash. And this is not the only one. Other cases, for example, some days ago reported, for example, in the New England Journal of Medicine, especially focusing on the genital lesion. This is imaged in clinical medicine, but also these case records of the Massachusetts General Hospital show, for example, in the penis, but also in the perianal region, these lesions related to monkeypox infection. But again, this rash is not the florid or extended number of lesions you will see from the African reports. And this is right now from outside Africa. These 1 or 2 or 3 lesions in the skin, you have to have a high level of clinical suspicion connected to epidemiological information that is important, as we have discussed in risk factors, groups on the risk and vulnerability. And you may see, for example, this assessment that also needs to include, for example, in these patients, for example, this kind of endoscopic examination. This is another case that may be confused with many other infectious, but not only infectious clinical presentation, and this was also a monkeypox. This is another case, for example, from Spain, from Madrid, recently reported, a patient with HIV. Many patients have been in this group, a 32-year-old man having sex with men, HIV under treatment with no detectable viral load, but with a past history of gonococcal and chlamydia trachomatis urethritis that was positive for monkeypox. This presentation is being reported in different publications, and we have this systematic review that will be in the next few days in Research Square, has been submitted for preprint and at the same time for publication. And you will see that we assess and we are specifically finding significant differences in the clinical presentation between the African previous cases and right now the cases reported in non-endemic African countries related to different clinical aspects, especially the genital ulcers and genital lesions. I have not much time to show this in detail, but I would like to show again that it's important to assess the risk groups. This is regarding probability. The European CDC is showing that a person with multiple sexual partners, including some men who have sex with men, has a high probability for monkeypox virus infection, but especially health professionals, healthcare workers, laboratory personnel with protect exposure will be a high probability, but especially laboratory personnel, overall risk of a high level. And we have to remember that risk may be even higher for certain people, including very young children. Now it's reported in children. You will see the news, pregnant women, elderly, or immunocompromised persons. This also include HIV population. Multiple algorithms in different countries are right now proposed. These are from United Kingdom, from different levels, individual and collective. I would like also to remember that from Africa, some case may have a fatal outcome, as this report, this case series from the Central African Republic. And this is important to remember. Patients may complicate, not presented only with the classical clinical presentation. The distribution of these lesions has been reported in this way in the past, but we need to reassess this and look at what is happening during this current outbreak. From animal studies, it's important also to see that the animal studies show a wide distribution of the virus in different organs, and this is also important to be assessed in humans, not only these past clinical presentations that has been reported, especially in Africa, but what is happening right now during this outbreak outside. As you may see, this paper with imported cases in United Kingdom, all of them unfortunately evolved in a successful way. No fatal case were presented, and this case received, for example, some antivirals, such as the case of brincidofovir and tecovirimat. And another important point related to this paper, the persistence of the virus in different compartments. As you will see here, for example, in upper respiratory tract for more than a month, also in blood, also in genital lesions, ulcerated lesions. And this is important to consider for the follow-up of the patients to understand better this disease. Obviously, we have to remember to the importance of detection from different lesions, especially active skin lesions for the PCR, this report, and also to reassess and assess, especially, for example, laboratory findings. There are not many assessments on this before the current outbreak. This is important to understand alteration, for example, in the white blood cells, in platelet count, in the blood urea nitrogen level, as well in the transaminase and the albumin level that may be altered in this patient. As I mentioned, this has been reported especially in HIV populations, and is important. From transmission, it's important to remember that this is a zoonotic disease originally, but also close contact, droplets, skin lesions are important sets under the questioning. We mentioned prolonged face-to-face contact, and probably sets as mentioned, contaminated bedding or blankets, and this is interesting also because, for example, from the WHO risk assessment, this is recent, this is not past, because there has been some controversy on this. Possibly short-range aerosols and in general aerosols need to be reassessed regarding this possibility. So in animal models, this has been assessed, and is possible from aerosolized monkeypox virus, for example, in cynomolgus monkeys, and the possibility to produce infection. This is a report with infection from that route, and we have to assess that in humans in detail, obviously from exposure to raw meat from different animals in DRC has been widely reported, is well known, and in general, the contact with different animal hosts is important. But this is a new report. This was published a couple of days ago in our surveillance, and this was the detection of monkeypox virus in surfaces, environmental surfaces at the hospital rooms of rooms that has been occupied by patients in hospitals in Germany. As you will see here, the virus was detected in different surfaces, in the bathroom, in the bedding, in the pillows, in different viral concentration, but not only in hospitals. This is a preprint already available from a few days ago in medRxiv, also showing in the United Kingdom that monkeypox virus contamination can be identified in domestic settings related to an important case in the United Kingdom. As you will see here, the viral load. This virus was detected in different items, in the mattress, in the sheet, in the towels, in the bedding. And you will see here, this was a micrograph from the monkeypox virus detected in the patient's bedroom, and it's important to consider this possibility. But this preprint from Lancet, preprints from Belgium in a study assessing males in sexual health clinics in Belgium from 224 males that were assessed. 3 were positive, which means 1.34% that were not symptomatic. So this is probably, at least during this outbreak, the first report on Polish about a symptomatic monkeypox virus. So this raises a lot of questions. Can be transmitted in a symptomatic way. Before I mentioned that the transmission occurs during the skin eruption period, but probably this report yield concern regarding this possibility if this is confirmed in other studies. And more studies are coming out, assessing different situations. The complications are still to be addressed in more detail. And it's important to mention that in the past, for example, from the case in the United States in 2003, some patients not only were hospitalized, but also admitted to the ICU, not only children, but also adults. And this is important to consider. This was a teenager that presented complicated cases, including a retropharyngeal abscess. As I mentioned, deaths also may occur, and this is still low, fortunately, but may occur. From the diagnostic, mainly the diagnosis of the monkeypox is made by PCR, but other techniques may be used or assessed, but the most important is the PCR from the lesions, especially from skin. It's important to look on others, but look on differential diagnosis, and after that, the possibility of genome sequencing in order to see which clade is causing the infection. From treatment, cidofovir, I already mentioned, brimcidofovir, the tecovirimat are being used in some countries, in the United States, in Europe, and in North America for the management of some of these patients. Vaccines, there are vaccines that have been licensed, and this is the case especially of Genius that is being used, especially in the United States, for pre-exposure vaccination of persons at risk for occupational exposure to this monkeypox virus. Obviously, the biosafety issues, the risk assessment is important under the exposure for healthcare workers, as I mentioned, and even this possibility of using Genius vaccine. And in fact, in the United States, for example, and Canada, as this picture published in Nature, is showing that monkeypox vaccination already begins in this population, and even has been offered in United States, for example, for the LGBTI population under risk exposure to monkeypox. Recently, and to finish, the World Health Organization from this meeting on research priority yielded a lot of research priority, for example, regarding antiviral vaccine research priority, and many other things that are important to be issued in different studies and assessment in different countries. But it's important, again, to remember differential diagnosis and to assess also the possibility of monkeypox even without travel-related history, as this case, for example, diagnosed in Boston, in the Massachusetts General Hospital. Differential diagnosis, many other pox viruses, as the cowpox, tanapox, molluscus contagiosus, but herpesviruses, adenoviruses, parvovirus, paramyxoviruses, such as measles, also mumps, H. dermatitis, hand, foot, mouth disease, rubella, arbovirus that are important here in the topics. And also I mentioned at the beginning of the presentation the case of hemorrhagic fevers, but many other, varicella, impetigo, herpes simplex, syphilis, tick typhus, chancroid, lymphogranuloma venereal, and many other may be the differential diagnosis. This is from a review article we already published to trying to remember this clinical presentation that may be a differential diagnosis of monkeypox. And this is a case also from monkeypox, from plague, from the group of the Dr. Bisova that is collaborating with us, that had this case with these lesions that was confirmed by PCR, but also by electron microscopy. And this patient already had HIV and syphilis. This was a co-infection with HIV, syphilis, and monkeypox, and that is also important to consider not only as a differential diagnosis, but also the possibility of co-infection. But as I mentioned, we have to remember this atypical presentation from these cases that are right now reported in different countries. To finish also, I would like to recommend you to download this guideline from the World Health Organization about the clinical management and infection prevention and control for monkeypox that cover multiple aspects from the clinical classification, evolution, complications, treatment, and different recommendations in different settings and algorithms that will be of interest for everybody. So I would like also to highlight the importance to be aware of different agencies and the assessment of the risk, even, for example, in travelers to countries with a high number of cases, and also what has been called in different publications, the importance not only to increase the research, but also to apply this knowledge to try to focus to most affected countries that include particularly the case of endemic countries in Africa that have been affected from monkeypox for decades. So to close, again, this image to remember that this is still is not a pandemic. I don't think it will become a pandemic, but it still is a matter of concern, and this is spreading with multiple gaps and limitations and key questions that have been raised in different webinars and presentations regarding this. As editor-in-chief of Travel Medicine and Infectious Diseases, I would like to invite you for this special issue or on emergent human monkeypox that is also open. And we have published already 12 articles, different cases, the first cases of Romania, Czech Republic, France, and Italy, and you are welcome also to submit different types of articles to this special issue. And I would like to close saying that here in Colombia, in our city Pereira, there are no foreigners We are all parents, and thank you very much. Muchas gracias.
Thank you so much. I'm sure you must be tired speaking over an hour. So, but we still have more to go. I think I will invite our chair, and we have question answers on the floor. So it's open for everyone.
Yep.
Dr. Chong.
Thank you, Professor Morales, for that wonderful presentation. I've learned a lot from today's presentation. Excellent references and beautiful diagrams. And didn't know there was so much work going on for monkeypox globally, but very, very informative and very enlightening. So I'd like to open to the floor now. I think we have a question from Dr. Mizuka.
Oh, thank you so much to you, Chair, and thank you so much to Prof for this comprehensive presentation. I'm also impressed that there's so much work that is being done regarding monkeypox. I've got very few questions, Prof, that I would like your assistance, in understanding. The first issue is the issue of monkeypox being less transmissible. Is it due to the character of, if you compare it to smallpox, is this due to the character of the lesions? What could be the reason behind that? I've noted already, that in our country, in South Africa, there's 2 cases identified already. And I mean, over a period, I think there's a gap of about a week or 2. The other thing that I wanted to deal with, Prof, is the issue that relates to the first thing that you spoke about, the issue of discrimination and the issue of stigma. I just hope that we can have a better way of presenting as scientists now, a better way of presenting our clinical information. Because when it goes out there, automatically, depending on how we present it, it causes what we don't want it to cause, discrimination and stigmatization. For example, the issue on men having sex with men. Are we saying that now this condition is a sexually transmitted infection? Or are we saying during a sexual intercourse, there is direct contact with the other person, and that would obviously cause the spread if those people are infected? So can we try and iron out this issue so that we don't find ourselves having people, gay people who are being now stigmatized and discriminated against? The last one from me is the issue of also that has something to do with discrimination. We noted that with COVID-19, what has happened is that when there was an Omicron case that was found in South Africa, everybody closed their borders against South Africa and other countries, the SADC countries in Africa. So if we are now introducing something that says the endemic areas are Central Africa and Western Africa, aren't we introducing that discrimination? And on top of that, how do you explain cases that were found in Europe and other countries with no travel history? Aren't they having endemic cases which they are not aware of? Those are the questions from me, Prof. Thank you.
Yeah, thank you very much. Very good questions, important points that we may discuss. The first, regarding to transmission, it's important to say that still we don't understand all the transmission routes, the importance of all of them, and particularly the impact and proportion of them, because we have respiratory, we have the droplets, we have in African countries the animal contact, but also the close contact, especially from skin lesions. And as I mentioned, this is not only transmitted by one route, but also it's important that the close, intimate contact is contributing significantly, and from the epidemiological point of view, it's important to say that these events related to, for example, gay pride, sexual parties, males having sex with male, have been related to clusters of transmission. But I would like also to connect this to your second point, which is stigmatization and discrimination. I think we as scientists and physicians, we need to have two different approaches, because from a scientific point of view, there is no doubt that the virus has been detected in sexual fluids, and this has been reported in different publications right now. And I am pretty sure that will increase over the next few days and weeks. The issue will be to confirm that this virus from these sexual fluids is also infected, is replicative in cell cultures, and that is of risk for transmission. But beyond that, from a scientific point of view, I mentioned that we need to have two different approaches. The approach, for example, in sessions like this, scientific sessions, but a different and completely different approach from, for example, social media, news media, in order to explain the importance of close contact, especially because, as I mentioned, even, for example, having sexual protection, the use of condom, this will not avoid the transmission of monkeypox, because the transmission is not occurring exclusively from sexual fluids. If you have a genital lesion, if you have a lesion in your arm, in your hands, or even in a leg or your groins, and you are using a condom, you will not avoid the transmission, because there will be close contact with the lesion, skin to skin, and there will be the possibility of transmission of monkeypox. So it's important for the people to understand that in general terms, this is a close contact transmission that is occurring with this disease, and this is not limited to sexual. This is not limited to LGBTI communities, for example. This is also occurring in children, and may occur in women, and may occur in people not having sex intercourse, but again, close and especially prolonged close contact. So it's important to have that careful discussion and careful approach to people to understand and to avoid stigmatization and discrimination. Regarding the third, I explained, and I think this is important right now, regarding the new classification of the virus. I perfectly agree with you, and we live that with COVID-19, and originally these variants of concern that were classified or named, especially according to the origin, for example, Alpha from the United Kingdom, Beta from South Africa, Gamma from Brazil, and Delta India, and Omicron from South Africa, as you mentioned. And right now it's the same. And further on, when people say this is an African disease, I usually say, no, this is not originated from Africa. This was discovered, in fact, in Europe. And we are not exactly the origin of this. It was, for example, Brazil, as I mentioned, there is a theory about that.
Oops, we seem to have lost Professor Morales.
Oh, yeah. Okay, so let's wait for him to join back. I'm sure he will be back.
Important to follow the clade classification to avoid that. And we have to follow this classification, clade 1 clade 2, clade 3. We are now naming according to the origin, but even we are also using the pangolin classification. For reasons of time, I didn't explain that, but we are also lineage that are based right now on the pangolin classification, as we did in the past with COVID-19. And that will also be important in order to avoid, for example, geographical stigmatization. I certainly agree on what you mentioned, and I think it's another important aspect that has been raised by the phylogenetic studies regarding the probably silent circulation and transmission in Europe before this outbreak, probably since 6 or 7 years ago. And this is an aspect that needs to be more carefully addressed in the near future with phylogenetic studies.
Professor Morales, I found the data you showed on the asymptomatic monkeypox infection in the swabs from the anorectal region. I found that very fascinating. Is it because the viral load wasn't high enough to trigger symptoms, or your thoughts?
Well, I think there is no data yet regarding that to properly answer that question. But I do believe based on the pattern of the virus, the probability is in relation to the viral load. We have to remember that this virus has at least 2 viremias, and that the virus may distribute, I believe, from the animal models to different organs and systems. And certainly, this detection in this anorectal swab maybe is related to that. But the thing is that probably the low level of the virus may not necessarily allow the clinical presentation of symptoms. But again, this is still very preliminary data, and we need to see more data related to this possibility of asymptomatic infection, because in the past, probably there was no a lot of molecular detection and also even genomic surveillance, and this is important and needs to be carefully also addressed.
Monica, do you have a question for Professor?
Oh, thank you so much, Professor. Your presentation was very elegant in terms of the data you presented in the historical origins of the virus and how we came from the original detection to where we are today, speaking both to the molecular basis of the virus, the biology of the virus, the epidemiology of the virus. You covered an exhausting amount of information that was just phenomenal. What I was just putting in the chat was I just wanted to make a comment. I think it's very interesting that we're seeing emerging diseases because we are now an unvaccinated population to the smallpox. And that's how we were protected for so many years. And I think it's more of a philosophical statement more than anything, is that as we become uninfected through natural infection, or we are unvaccinated, we are now going to be susceptible to more and more diseases. I believe that the SARS-CoV-2 pandemic is just going to be kind of our timestamp marker of understanding viruses, emerging viruses, zoonotic diseases, finding new hosts. Like now, I think we've all become infectious disease specialists, by watching the pandemic. And your presentation just touched on so many concepts, but I wanted to highlight that your vaccination efforts, modeling over now the pandemic vaccine efforts, do we really need to look at this? We're looking at a virus that's not as transmissible. We're finding a very specific population right now that's susceptible. But are we really putting all of ourselves at risk if we don't take this virus seriously? And do we need to expand the criteria for those who should receive the vaccines so as to make sure that we are not causing super spread events unknowingly? So it was more of a comment than a question, but I just wanted to say thank you for raising all of the concepts you did.
Thank you, Monica. But in connection to your comment, I think it's important to highlight that right now, WHO is not recommending mass vaccination, but certainly, I think right now it's important to consider that high-risk groups should be offered for vaccination. And I think this is beyond healthcare workers and beyond LGBTI community. But I think probably we need to assess in different countries the risks in other populations, especially immunocompromised patients, elderly, young children, and many other high-risk populations that maybe evolve with complicated forms, which is still an issue that we need also to address specifically to see which is the proportion of these cases caused by the clade 3 that may be evolved to complicated forms of monkeypox virus disease.
Thank you.
Dr. Chaudhary?
Yeah, thank you. Thank you so much, Dr. Alfonso, for a nice presentation. Actually, I just writing where you are showing that our 0 is 2 to 3. And in case of coronavirus also, it was 2 to 3. Sometimes it was showing more than 4, 5, 6 like that. So why the number of cases are less in that case? Is it because the containment or the preventive measures already taken by the, and moreover, because of it's not due to droplet infection, it's only the due to the cutaneous starch and other is it things. And number 2 question is in subcontinent mostly the people are vaccinated with smallpox vaccine up to 1980. So still those people are protected by those vaccines or not? Thank you.
Well, for the first question, I think it's important to consider first that we are reassessing that. Regarding the transmission, there are obviously multiple factors, and still we need to reassess, for example, the basic reproductive number. This is right now under assessment. The probably low transmission compared, for example, to COVID-19 is related in part to containment. I think clearly, for example, in some countries and some regions, I may speak clearly for multiple countries in Latin America where I work and I collaborate closely, that the capacity for the containment, the detection, the surveillance, and many other aspects right now has been enhanced after the COVID pandemic. Just to give an example, for example, here in Colombia, we have in 2020 only 1 laboratory with capacity to detect COVID-19, and right now we have over 3,000 laboratories to detect the virus. But in addition, we have only 1 laboratory for genome sequencing, and right now we have over 100 in order to do that. That is important to make a point. But again, we need to assess specifically, for example, that relation to the way that is transmitted the virus outside Africa right now in this outbreak. Regarding the smallpox vaccination in the past, what has been stated by some data is that around 85% of cross protection occurs with the people that were vaccinated with the smallpox for the case of monkeypox. But this is still something that I believe need to be addressed in detail, because furthermore, the proportion of people in that condition is low. As I mentioned, is less than 10% of the world population that is in that age group. And secondly, we need to assess that immunity, and we may assess that immunity, that cellular and that humoral immunity to smallpox, and in this case specifically to monkeypox. That is possible to do to do it, and is an important question that probably in some studies in the near future will be addressed too.
Thank you, Professor Morales, and thank you, everyone. I think we're kind of running out of time, so thank you so much for your lovely.
Can I give last comment?
Dr. Bukhari?
Okay, thank you very much, Dr. John and Morales. An excellent presentation, but at the end, it is my suggestion. It is not the question. I am basically professor of pathology in Pakistan. I am dealing so many cases of the viral infections. First thing, I will disagree with this. This is not a sexually transmitted disease because the viremia in the semen is for a short time, and the transmission is through the infected skin, not through the semen, one thing. Second thing, that viremia in the blood is for a shorter time, that is even the blood, infected blood is not a source of infection. And the third, through saliva, it is not transmitted. Basically, the monkeypox disease is the disease which is transmitted through the infected lesion, one thing. Second thing is that this is the time now to give the suggestion to the WHO that we have also recommended and sent the letter from the Pakistan to that. This is the time to change the name, not the change on the clades of the clade 1 or clade 2 or clade 3, just one thing. And that is why thankful to the WHO, they have accepted this request on 15th June and this last June, and they are now handed over the request of different scientists to give the name of alpha 1, alpha 2, or beta 1 or beta 2 and something else. And the third thing, that is the vaccination. The vaccination, no doubt I agree, the vaccination is but this vaccination, the prevention is much better as compared to spreading the vaccination, because still in USA and other areas, the vaccination is not at such amount to send this to the countries. And I request the peoples who are in the non-endemic area, this virus is no more monkeypox virus. This virus has no more than 50 mutations. That is why I think we have requested the WHO to rename it, to decrease the discrimination, the stigma to people after. I think Dr. Akhtar Hussain is not here because he last week told us that there are 1 or 2 cases without any history, without any contact to this one. Thank you very much once again. Inshallah, see you next time.
Thank you, Dr. Bukhari. I'm in here all the time. Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
Dr. Morales, Professor, any comments?
Yeah, I would like to remember that sometimes may be confusing when we are discussing about what is detected related to this virus. As I mentioned, this not can be still named or classified as a sexually transmitted infection, but is a question and has been detected in sexual fluids, and as I mentioned, has been not confirmed the detection in cell culture, for example, has been not assessed the infectivity, but has been detected in seminal fluid, in semen, as I mentioned. And probably, as I mentioned, what is important is to consider that as a possibility, but not as a main route of transmission. As I early discussed and I mentioned, even in another question, is that the close contact during sexual transmission or without sexual contact is of risk for that. This is an important thing to consider, but certainly some clusters related to sexual contact have been important and have been demonstrated in different studies regarding that. Also, finally, regarding the place where we agree on that and the importance of this classification to avoid discrimination. And regarding to vaccination, it's not only the case for the monkeypox and probably for any other, is that certainly vaccination is not the only one tool for any disease. And we need also to focus on education and in general prevention in different ways, not only the community, but also well-based and well-informed healthcare workers in order to provide evidence-based information regarding this emerging disease. Thank you very much.
Thank you very much. Thank you.
Thank you, Professor Morales, and thank you again for your wonderful presentation and all the questions and comments that you've given us. And we look forward to seeing you another time. And thank you everyone for joining us today. And
Dr. Chong,
we'll
Dr. Chong,
meet next week for
Dr. Chong.
Yes, Dr. Sajat.
Yeah, thank you very much. Actually, I have some net problems, so I could not regularly join the meeting. But I have a different questions from you, especially, and Monica, and any expert person. People are talking about the third booster dose for coronavirus, third and fourth booster dose after 4 months or 6 months. Is it true? Is it true we have a second booster dose as a health workers and the other people? What do you recommend? Thank you.
Dr. Sajat, maybe I'll try to send you some stuff in our group chat about this.
Yes.
And we will let Dr. Morales go. He's
Yeah, I think it's the longest session we have ever had.
yeah.
So thank you so much, the speaker, and we should wind up the session right now.
Yeah.
In the interest of everyone's, and we can take all the question answers next time. We will try to see if we can bring more speakers on these things.
Thank you so much, Rab. Thank you so much. Thank you very much. Thank you.
Thank you.
Goodbye. Goodbye.
Bye.
Thank you, everyone.